So while the last few of you come on in and get your food, I will go ahead and do introductions. Dr. Ram is out today. So it is my pleasure to introduce Dr. Chichu from the VA. She came over from Beacon Hill. And I believe I've introduced you before a couple of years ago. And so Dr. Chichu comes from kind of across the coast, from the East Coast, stopping briefly in Chicago, but then came to the VA in 2008. Where she's a clinical neuropsychologist working in the memory disorders clinic there, and does research on aging, PTSD, cognitive decline, and basically all those things lumped up in very different research areas. And then today she's going to talk about those things, aging, PTSD, and cognitive decline. So without further, welcome.
Thank you very much. Welcome, everybody. Thanks for braving the cold and being willing to give up that sunshine at the same time to come hear the talk today. I have this poll up. I probably am going to move on from it in a few seconds. The poll is asking about working with older adults or those with PTSD diagnoses. We're starting to see the trend of what I expected to see, which is that a lot of people are working with these populations, sometimes in tandem, sometimes separately. I would argue that even if you think you're working with one or the other, the likelihood that they're going to cross over at some point is quite high. So moving forward here, here's just the title of the slide in terms of thinking of our veterans that have PTSD who are getting older and also might have cognitive concerns. So interestingly, the slide I am showing is not coming up on the computer anymore, but that's all right. I'm going to just be looking then. Maybe Josh, you could take a peek at that. So in terms of disclosures, I don't really have any disclosures. The only disclosure is that I'm pretty opinionated, and so the things that I will be saying today are my own and not representative of the University of Washington, and certainly not of the federal government necessarily. I've got a few learning objectives. Definitely my goal today is to have you all feel more confident in your ability to recognize PTSD in older adults, and also maybe some of the cognitive changes that are occurring in these folks, to have some confidence or some knowledge about ways to treat PTSD in older adults and take action on cognitive impairments that may exist. And then also think about some methods, supportive methods, monitoring methods for these individuals moving forward. So there's kind of one last disclosure here, and that is that I am not a PTSD expert. I am a geriatric neuropsychologist. I know a lot about dementia. I know a lot about aging, but there are probably people in the audience who know a lot more than I do about PTSD itself. So this is going to be interactive, hopefully. Jump in, participate. I would want to hear what everyone has to say. When I joined the VA in 2008 and joined that memory clinic there, having come from other memory clinics in my past, colleagues and I were pretty struck by the fact that we were seeing an uptick in these, what I call younger older adults, folks in their late 50s, 60s, early 70s with cognitive concerns. And we're doing this specialty clinic where we're doing evaluations, and folks are rarely getting a dementia diagnosis. Sometimes there was some evidence of objective cognitive problems, but really mostly just subjective complaints. Folks didn't have true losses in independence, and yet their symptoms were really having an effect on their day-to-day function in terms of, lots of concerns about forgetting medications or events and things like that. And at the end of the day, there was this sort of gray zone that they were existing in. And for me, the gray zone had always been between normal cognitive aging and dementia, and that gray zone was called mild cognitive impairment. That was always so easy, right? That's what I was trained in. These guys weren't fitting that. Their gray zone was not MCI. And really we realized that the common element was that they all had post-traumatic stress disorder. So that's what I'm talking about with PTSD. So that gray zone was what I got very interested in at that point, in addition to mild cognitive impairment. And we even developed a clinical demonstration project, which I'll be talking about more at the end of this talk, to try to address some of those perceived needs. I'll tell you that when you have someone like this in your office and they are in this gray zone, simply saying, okay, you're fine, you don't have Alzheimer's, go home, doesn't feel very satisfying for them or for us as providers. So trying to put this in context a little bit, let's imagine, and I'm just going to apologize that a lot of my older adults are always going to be referring back to veterans because that is the clinical population that I work with at this point. And I'll try to make specific comments when things are definitely not generalizable. I mean, a lot of this won't be because of the military service that these folks have done. So I have a veteran first here, John. I've named him, very cleverly named him. He's 69 years old. You can see some of the background information. He was drafted to Vietnam, spent just 2 years in the Air Force, non-combat status. And by his own words, when he came out, he had some years of hard living, mostly heavy alcohol use. But he met his soon-to-be second wife. As he put it, he got sober and got a real job. And so he then had a period of relative stability and success. He worked as a long-haul truck driver. He had issues with chronic pain and had a new injury, and then became retired and disabled. Both things he did not particularly want to do. He has a number of health risk factors, chronic conditions. He also has poor sleep. And no one's really explored that. He's never really explored it. You know, obviously for a chunk of time, he drank to help with sleep. And in the interim, he's been trying other things, but without much benefit. And he's had a lot worse sleep recently in the past. And his wife's the reason he's in the clinic. This is not uncommon. She's not happy with him. He is hiding out in his garage all the time. And she feels like he is not ever remembering anything that she tells him, things to do, places to be, things like that. So, anyone see or hear any red flags already? So sleep, yeah, I'm hearing that, you know, the sleep stands out. That's a problem, and that's been a really chronic problem. But I think what we also might want to be thinking about is, well, why is it worse recently? And what are the characteristics of that? That certainly could affect thinking. Anyone else?
Vascular risk factors.
Oh yeah, we've got a big, someone said vascular risk factors. We've got a bevy of vascular risk factors, cerebrovascular risk factors, cardiovascular risk factors. What about the hiding out in his garage all day? Anything come to mind for that? I see heads nodding. People are trying to eat their lunches. So I hear that, and I think sometimes coming from a memory disorders perspective, I'm thinking about sort of people kind of socially isolating when they're having trouble keeping up with things and not remembering what's been going on lately. In this case, though, this guy's memory was fine. It was that he was isolating more due to what turned out to be PTSD symptoms. So these symptoms, I guess the message I'm trying to say here is that there's a lot of overlap sometimes in what I might hear in clinic and what you all might hear in your clinics, even if it's not a memory disorder setting. Now, coming from more of a psychiatric practice, you might be better tuned than I was, or at least I used to be, to hear some of these things. But maybe you also would want to be coming at it and also thinking about whether it could also be a memory disorder perspective as well. So the first goal here is to recognize what might be going on. And we've heard of a number of things that are possibilities. And so we want to tease this apart. Before I really jump into that, we have to think about, well, how prevalent is PTSD? How big of a problem is this? It's a decent problem, decent-sized problem here. Now, the one important thing to know is that trauma exposure, stress exposure, does not equal PTSD. There's been a number of good studies that suggest that half or more of the population, just the general population, does get exposed to trauma at some point in their lives. And there's a little differential between men versus women. And then certain areas of the country have been shown to have trauma exposure as high as 90%. And then when we think about then PTSD, our rates of PTSD aren't over 50%. However, a certain percentage of people who've been exposed to trauma do develop PTSD. And looking at the United States, there's about a lifetime prevalence that's been indicated at almost 7%. And in those 60 plus, that rate was actually only 2.5%. So that was lower. Although I would argue that the design of this study, the National Comorbidity Survey Replication Study, was such that we're probably missing some people of our most vulnerable older adults, those who are physically disabled, maybe already have cognitive impairments. Anyone who's homebound or in long-term care would not have ended up in this study, or unlikely to have ended up in this study. And then we have certain populations within our population that have a greater prevalence of PTSD, and veterans are one of those populations. A study of all age veterans at all across the board came up with an 8% lifetime prevalence. That's obviously higher than the general population. And then we have to think about, well, how many people is this? And there's over 9 million veterans who are over age 65 out of our larger population, which is over 46 million people. These numbers are from 2014, by the way. So what about the folks I'm seeing? I'll tell you right now, the bolus of vets that I'm seeing in my memory disorders clinic now are Vietnam vets. Vietnam vets actually have a higher rate of PTSD prevalence in that population as compared with World War II vets and some other groups. So a study that looked at the this population had a pretty decent N, over 3,000 veterans who were selected to be a representative sample. And in that group, the estimated lifetime prevalence was about 30%, 31% for men, and 27% for women. Some have argued that that's a little liberal of an estimate. When I found my most conservative article, it was still at a 19% lifetime prevalence. And so these are pretty significant numbers. And then we also have to think about, well, what's the next wave going to be? And this is how I operate in the aging clinic. And that's our Operation Enduring Freedom, Operation Iraqi Freedom vets who are coming along. And we could have a whole discussion about what the possibilities might be or the reasons for this, but all the estimates are suggesting that the PTSD rates are as high as 23% in these veterans. So pretty concerning that even though we have all this extra attention being paid to PTSD now, and there's a lot of resources out there, we're still having the development of somewhat of a chronic picture. So what is PTSD? The behaviorist in me loves this description. It's a survival response gone awry. Now, if I could tell you exactly how PTSD forms and exactly what it is, I'd be very happy, and we'd probably be a lot further toward getting rid of it. But it's a complex process. We have this, some sort of a stressor, a trauma that induces the stress response. It's engaging the sympathetic nervous system, we know. And if we think about this from an animal perspective, it's life-saving initially. You either fight or flight, right? You either get out of there or you attack to neutralize the threat. However, when this response continues, when there's no longer that threat in place, it can, or even if the threat is still in place, it will overwhelm the organism. And then a lot of studies have shown that it can be more damaging than even the original stressor, minus the whole possibility of death, of course. I heard a great talk recently by Jason Stewart, and he likened PTSD to the Incredible Hulk. He called it the Incredible Hulk syndrome. So everyone here, anyone familiar with the Incredible Hulk? So for me, from my generation, it all comes from the TV show. Those are the images that come to mind. And basically, Dr. Stewart described this as a situation where, the scientists got exposed to gamma rays, there's your trauma, that induced the Hulk. And then from that point on, and it actually kind of generalizes and accelerates, when exposed to strong emotions, he turns into the Hulk. But so then we see over the course of this television show, and I'm sure it happens in the comic as well, that he starts avoiding positive relationships because those emotions, strong in any direction, could trigger the Hulk. Everything becomes internalized as a threat. These consequences build up over time. They follow the scientist along. He starts to look in the mirror and see the Hulk. He doesn't even see himself anymore. And he begins to distrust others and any systems that government systems, of course, because they're the ones who induced the gamma rays. But anything that could be supportive actually gets rejected because of that need to disaffiliate. So I think what I like especially about this is to remember that what starts off as sort of a very specific stimulus and response can really generalize and create this cycle that is not supportive toward any sort of positive change in the future. Research, there's tons of research out there just talking about what the stress response and what PTSD can do to you over time. I just found this one figure that I thought did a nice job of sort of summarizing all the different systems that can be impacted. And then thinking about long-term impact, I think you can see pretty quickly how this could be very deleterious with aging. So I'm certainly not going to sit and go over the DSM diagnosis of PTSD with this group. But what I find most interesting, there's two things I love. One, with the DSM-5, they really did a good job of pulling in that fight. That's not just the flight response, but the fight response as well. And with these 4 distinct symptom clusters, that really appreciates that that can be one of the reactions. And then I have highlighted here in red how many of the verbiage in these symptom clusters really associates with memory and with thinking changes. PTSD, in fact, has been referred to as a disorder of memory. And so we want to keep that in mind as we query people about symptoms. So in aging, PTSD might not be so obvious, and we might not always think to ask about it. And we also want to be thoughtful about the ways that normal changes in aging or neurodegenerative disease changes in aging could also have an impact on this relationship. So in older adults, it's been suggested that the problems can broaden, and there's a dysregulation that occurs as these PTSD symptoms become more chronic. That hyperarousal that at one point was a very focused hyperarousal actually turns into sort of a more disordered arousal. And I also want to really highlight that a lot of times the symptoms are subthreshold. You know, I mentioned that in the older adult sample in the United States, it was like 2.5% prevalence. Well, in the Netherlands, they had a study that looked at their older adults, and it was just under 1% lifetime prevalence for their over 65 population. However, they thoughtfully included the folks that were just sub-threshold for diagnosis, and their prevalence rate went up to 13%, just with a slight tweaking of those numbers. So not everyone's going to meet full criteria, but if you're working with an older adult, asking about these types of symptoms and having this be a possibility in our minds is pretty important. So in older adults, for a lot of people, chronic PTSD looks the same as their earlier PTSD. For our veteran John, you know, his earlier PTSD was covered up with a lot of alcohol use, and he, you know, might have appeared more antisocial and also these sorts of personality things we talk about with his not being able to keep a job. And I didn't go into whether he had any scrapes with the law, but that might have happened along the way as well. But so for him, it might look a little different, but still those core features might be the same. Whereas for some older adults, the symptoms seem to emerge after retirement or maybe after a chronic illness is diagnosed. And some talk about it being late onset PTSD. Has anyone heard that term before? Late onset. That was when there's a body of literature about that late onset stress symptomatology. A lot of the other folks in the field of aging and PTSD talk more about delayed recognition or delayed emergence. For me, that kind of fits better because I don't think that those things ever didn't exist. It was just sort of how someone was able to inhibit them or cognitively basically control for those symptoms. However, pulling up some information about the late onset stress symptomatology, I think, is useful for conceptualization. We've got these older vets. They actually did have high stress, high trauma back when they were in their service years. They've seemed to have functioned pretty successfully, and they don't have a psychiatric history of treatment for substance abuse or other disorders. But as they're getting older, they are actually starting to think about those days. And it's becoming distressing, especially as they're confronting challenges of aging. So for some, it might just be sort of a disconsonant thoughts and part of their adjustments as they're aging. For others, it could be quite distressing. So here's sort of this schematic representation of loss. And you can see how you have your antecedent. It doesn't have to necessarily be combat experience, but that's what they put in here. And then there's the correlates. There's either protective factors or aging factors that can come into play. And then the outcome being sort of either the emergence or exacerbation, one could say, of these symptoms. And looking at these here, I think what's not here, actually. So they've got retirement, illness, death of a significant other, maybe financial shifts. I definitely would say since 2008 with the recession, a lot of folks came into the VA, and stresses about money were very problematic, especially as they were having physical disabilities. But there's also protective factors, self-esteem, mastery, coping, style. Sometimes, though, those lower ones, those protective factors, are getting eaten at by age. And I also think that what's not on here that I find most interesting is that the cognitive losses that might be going on, either through normal aging, which we all kind of are subject to, or through the beginning of a more pathological process, can really erode the protective factors and exacerbate these other health factors with aging. So moving forward and thinking about treatment, I promise you, as a non-PTSD expert, I'm not going to tell you exactly how to treat these veterans or these other older adults. First, though, let's think about John. So smart providers that you are, you thought, you know what, I need to do more of a mental health intake, whether it was within the setting of the memory disorders clinic, which we did do, or if it was outside of our time or purview, to have them go see a mental health provider. And what came out a little bit more in that interview was that I kind of alluded to this earlier, but he didn't want to stop working. The disability forced it. He's now spending all this time at home with his wife when he used to be out on the road as a truck driver. And so that's creating some stress and tension. You can imagine there's money stresses along there too when someone retires at a time when they did not plan to retire. Asking more about his experiences in Vietnam, he wasn't in combat, but he was in charge of med evacuations and basically loading bodies onto the planes. And this is what he did day in and day out. Sometimes folks he knew. He was given a geriatric depression scale, scored in the severe range on that. Nightmares were explored more. That was the cause of the sleep problems, or at least a proximal cause of the sleep problems. He didn't used to have vivid nightmares about his experiences in Vietnam, but he's having them now. And actually, it wasn't even just limited to what he had experienced. You know, these things were now loading bodies of people he knew now, and much more vivid scenarios. And even during the day, can't stop thinking about those days. When he was administered the PCL, which is sort of a screening tool, and then the full CAPS, which assesses for PTSD, he came out as positive and a diagnosis was supported. So what would you do next? Done? Send him off for PTSD treatment? Anyone have any thoughts?
Mocha?
Oh my gosh, Kathy, it's Kathy in the back. Someone yelled out mocha. Absolutely, and I'm gonna come back around to that. But I would say that it's easier said than done to be like, okay, send him off for mental health treatment. So at this point, I do think one wants to think about PTSD treatment, but you also really want to work with this guy and talk to him. His first reaction may not be, oh yeah, throw me in prolonged exposure. So it may be helpful for someone who's never had any psychiatric treatment before, or thought he had any mental health issues before, to kind of ease into that. So again, as I said, I'm not going to go over in-depth PTSD treatment, but there are a number of excellent evidence-based treatments that are supported. The American Psychiatric Association, of course, has practice guidelines. The VA itself, its #1 recommended tool is prolonged exposure therapy, but it also it's very supportive of using cognitive processing therapy, conjunct medications for SSRIs to treat the depression. I'm guessing that most of you know about these different therapies. The first two involve imaginal exposure, and prolonged exposure therapy also includes in vivo exposure. There are some lovely studies that have found large effect sizes for these. And then EMDR is up here. It's an interesting one. It's this eye movement desensitization process. There's less evidence to support the eye movement part of it as being critical, but at the end of the day, they have shown people having benefit for their PTSD symptoms. And sometimes I'm kind of a spoonful of sugar makes the medicine, however it's going to work. If that idea that they're reprogramming themselves by moving their eyes in certain manners is helpful to cognitively move forward and emotionally move forward, then I should not judge. Oh yes.
Why in this case would your leading diagnosis not simply be major depression, geriatric depression, with morbid thoughts about the past driven by depression? Why would the whole concept of post-traumatic stress even be that illuminating? I mean, we're making that didn't happen. So he's later in life he's depressed. He's having depression through morbid thoughts about the past. Why is a post-traumatic stress concept illuminating? I really don't get that.
Yeah, so this is a really thoughtful question for those that are on Zoom. Why am I jumping, or why are we? I wasn't necessarily the person who diagnosed this individual, but why are we jumping to PTSD? Why wouldn't major depressive disorder with thoughts of the past, rumination, and these features be the diagnosis and be the focus? I can't answer that.
Why would it be helpful?
Oh, why would it be helpful for it to be?
I really actually think the concept for the horse here is that you've got a depressed elderly man with depression that left over. The whole idea of training this into a post-traumatic stress concept seems to me actually backwards.
Okay. So the argument is that it might even be backward to call this post-traumatic stress disorder. I'm hearing, I think also, especially if the argument would be to then revisit those traumas and do one of these very PTSD specific types of therapy, would it not be more helpful to come at this from more of a major depressive disorder with appreciation of all the features? I think that's really legitimate. I think there's more than one way to skin a cat. I think that at the end of the day, this person getting treatment and support is more important than exactly how you do it. In this person's case, though, and especially coming from a VA context, there's a lot of side pieces to being diagnosed with PTSD in terms of service connection and the network of support that exists. And so that can be of huge benefit. There would be no co-pays for visits. Yes.
We did talk about psychiatric validity. I'm not too clear.
Yeah, no, so the question is, he's understanding that I'm saying that there's these systemic issues involved as well, but that from a psychiatric validity standpoint, and I think what we'd have to do, and you could argue that the DSM-5 is kind of useless. Why be binning people? Why not just think more about the symptoms and work from there? That might be beyond my scope today. But no, I hear what you're saying. I think you might just have to trust me that in this particular veteran's case, this has been something he'd been struggling with his whole life, and it was just really starting to get to him now, and it really did beautifully meet the criteria for PTSD. He also met criteria for major depressive disorder as well. And then there's pharmacotherapy. I'm certainly, as a PhD, not going to talk to MDs about pharmacotherapy in detail. I would say this, though, that one of the two most recommended SSRIs are sertraline and paroxetine. But unfortunately, paroxetine is on the Beers list in terms of thinking about aging effects with the anticholinergic profile with that. So you always kind of, again, when you're working with older adults, you may have your best practices, but those were all developed based on younger adults or just on men or just on women, and we have to think more broadly. Prazosin is often used and was prescribed in this veteran's case. It's been shown in research by folks that are local to help with insomnia, nightmares, and even daytime hyperarousal symptoms. Again, though, working with older adults, you have to be really thoughtful in using it. It has some antihypertensive effects, and you want to think about the timing of when someone takes it, whether they're going to get up quickly and lose balance. So there's always this full picture to think about.
I have a question.
Yes.
On that one. So what was this John exposed to? So he was doing the planned exposure. What would you expose someone like that?
So now this is again, so this is where I do not do PE. I do not do these treatments myself coming from a dementia perspective. I think that the exposure to body bags, I think in his case, you might be more realistic not doing prolonged exposure therapy, but doing cognitive processing therapy, where you're doing more working through the images in his mind of these things and kind of trying to go back and recontain what those images were associated with in the past, and that he's not being exposed to body bags now. He's not loading friends onto airplanes. So yeah, there's a lot of ins and outs there with doing the therapy that I'm afraid I am not the best to talk to about it. I think individualization, and this probably gets to the other point from the back, is that you don't want to just blanket apply these treatments. I realize that they're considered to be the guidelines, but they're guidelines. Clinical expertise is important to employ as well. So barriers to implementation, exposure doesn't get used that much. And it's argued it's underutilized. There's a lot of reasons for that, and many of them are good. There's a lack of training. No one should just jump in and try this one out. On the other hand, it's not that hard to get training. If this were a direction my practice was going, I know I could have done it yesterday. Well, not that easily, but pretty easily. Also, the trickiness of comorbid psychiatric conditions, substance use, abuse. Does someone need to be off alcohol before trying to work on their PTSD symptoms? I think the answer is pretty clearly no, but that makes the treatment sometimes more challenging, and the comfort level for the provider can be lower. Thinking about depression, bipolar disorder. Also, a lot of these folks have had head injuries. There may be other physical injuries, and being really thoughtful about those conditions and how they may have an impact is recommended. So for older adults, guess what? I know you won't be too surprised, but I was when I started digging in years ago. There's such a paucity of research in this area, despite what a huge number of individuals we have that are older who have chronic PTSD. It's a growing body of research, so don't let me be too negative here. I think what kind of gets in the way, though, these cons I've listed, that there's a lot of argument that, well, they have so many other health problems. My vet that has uncontrolled diabetes and hypertension, and maybe has some weight they need to lose, and they're like, why? This is not the low-hanging fruit. Let's go after that first. Arguments that older adults are not psychologically minded. I don't think this group has those viewpoints, but it is kind of prevalent. It's prevalent among the individuals themselves, especially my veterans. Like, oh, I don't think like that. And then a few minutes later, they'll talk to me about some article they've read, and they've had this in-depth psychological analysis of what's going on. And it's clear to me that that is a capable, they have the capacity for that. So gently introducing psychotherapy and cognitive behavioral therapies is maybe the way to do it, but not to avoid them. And in the pros category, a number of authors have used exposure therapy in older adults. There's a lot of case reports out there for what those are worth. And if you're thinking about engaging with an older adult and you've not done that work with older adults before, you might want to read some of those. But it's been used safely and effectively. So, and then the other thing that we should remind ourselves of is that the efficacy of CBT in older adults with depression and generalized anxiety the evidence for that's quite strong. And so the overlap between these types of symptoms, again, as pointed out, is huge. And you can certainly be addressing part of the problem, even if you're not jumping right into prolonged exposure or cognitive processing therapy. So access is an issue, though. I mentioned that exposure is underutilized. We know from Jurgen's own work that older adults don't get treated for depression as aggressively as younger adults. And then looking specifically, even in a VA setting, I'm so proud of the mental health services at VAs, but even in a VA setting, this recent study found that of adults over 50 who got a new PTSD diagnosis, not unlike John, that about the good news is about 75% actually did get some form of mental health treatment, at least one visit within a year post-diagnosis. The bad news is, though, is that over 65, they were actually significantly less likely than those younger, older adults to get services. And the 65 plus were more likely just to get medication, whereas the younger, older adults were more likely to receive only psychotherapy. And the older adults, and by the way, I feel silly calling 65 plus older adults, but in this group, that's how it broke down. They were less likely to receive combination therapy, pharmaco and psychotherapy. And additionally, another for follow-up analysis showed that they had fewer visits of any kind with mental health providers, even though if they were among the group that did get care. Now, there could be a bunch of reasons for this, right? Health factors, difficulty with transportation. I don't mean to put it all on the VA providers. I think what it says, though, is that we need some follow-up research, but in the meantime, why not put a little extra effort on our parts into engaging these folks and trying to make sure that we're not jumping in one direction or the other. I found it interesting about the medication for the 65 and older. Most of the older adults that I'm working with, they don't want to take a medication for their mood. And they may not want to jump into the hardcore PTSD treatments, but they're much more interested in some psychotherapy, behavioral activation, and things of that nature. So, back to John here. He was diagnosed with PTSD, despite the fact that there's a couple different things and directions it could have gone. That was an important thing for him. It got his service connection up to where he did not have to pay for his VA services. And it was never that much money, but copays really do add up, especially if you have weekly visits or things like that. And then the question really was what treatment to initiate. We did not initiate CPT or exposure therapy with this individual. He did engage, though, in some more sort of general CBT psychotherapy and praise-assist. Let's see. But this came up earlier when someone said, well, what about a MoCA? What's going on with his memory? I'm in the memory clinic, so of course we did this. He had an evaluation. He'd had these memory concerns. But I want to say, though, that jumping to a memory evaluation isn't necessarily what most people would think about because of all these other factors. The onset of his memory problems perfectly coincided with his retirement, with all these new stresses, with his health decline, with the nightmares kicking up and his sleep getting even worse. And so the question could be, was it all just PTSD symptoms, and should we just address that first and see how it goes? Maybe it was the fact that he just stopped doing anything when he retired. That's a real problem I run into. Also, though, where my mind goes is could it be early signs of dementia? That's what his wife was worried about. And maybe there was just some aspects of normal aging. So what are the cognitive effects of PTSD? In younger adults, there are, and I say younger adults, just under 55, under 60, there are absolutely some objective cognitive effects. They're generally mild. And the sorts of things that we neuropsychologists get really excited about, on average, there's a 0.5 point difference on this memory, this wordless learning test. And it's significant when we've got 1,000 people. Clinically, I just want to stress, you're really not going to see a huge difference. And it's in some pretty specific areas. Tasks that require attention, like complex attention, inhibition, maybe that new acquisition of new information. How much can you absorb on a first trial? Things like that. Another study found it was really restricted to executive function and processing speed. This is sort of this frontolimbic way of looking at the neuropsychological dysfunction. Also, interestingly, in case I'm sure some of you are working with people that have had mild traumatic brain injuries, that they're sure it's all about the mild TBI, definitely assess them for PTSD or PTSD symptoms. The research suggests that in terms of chronic effects, there are no cognitive chronic effects from mild TBI, whereas PTSD is associated. So if you control for PTSD symptoms or that diagnosis, those objective findings disappear. So looking at older adults, because that's who we're supposed to be talking about, there is sort of that group has been looked at specifically, and there is a lower neurocognition. Anybody want to guess what that means? that means they only gave an MMSE or a MOCA. So in this meta-analytic study, they included, they were all very good studies, but some of them, their cognitive assessment was simply a MOCA or an MMSE. And they've had very strong results with those. But so looking at the effects of the studies that had a more extensive battery, the largest magnitude of effect was in new learning of memory, and they did not find this processing speed piece, the timed versus untimed. So a slight difference from what was found more in the younger population. Any questions about that? And then there are some studies that did not just look at vets, because all of these were focused on veterans. Some of them included other groups. There are some studies out there looking at victims of war in whatever manner, refugees, survivors of abuse, and it all gets much muddier after that. And each study seems to have found some pretty different results. So it's hard when you start to include that. So cognitive effects of PTSD, while not hugely observable day to day, they do exist. But what about aging? And so the truth is aging has a much larger effect on our thinking ability. And it's somewhat inevitable given that the alternative is to not age. And the really sad part is, I hate to tell you guys this, because I think looking around this room, we've got most people are 25 or older. Processing speed just starts going down. This is an old figure. This is from a study published in 1996. I love it though, because it was the Seattle longitudinal study of aging and cognitive features. So it's from this area. It used some older tests, so some of these names, inductive reasoning, spatial orientation, aren't necessarily the way neuropsychologists kind of talk about thinking abilities these days. But you can see that some things start to drop early. But there's kind of an inflection point there, late 60s, where some of these other processes do seem to show a regular decline. So is this normal, though? I want to say the first message about cognitive aging, or normal changes in cognitive aging, is that as folks get older, there's more and more heterogeneity among their cognitive profiles. So if you've met one older adult with or without a memory problem, you've only met one older adult with or without a memory problem. You don't want to make assumptions. However, these big research studies and meta-analytic studies do tend to find kind of the same things across the studies. Processing speed decreases. Immediate attention span holds steady, but that complex attention, being able to multitask, divided attention, pay attention to something here, but ignore all these irrelevant stimuli, there are some small declines there. Among memory, we neuropsychologists love to split up between declarative and non-declarative and different stages of memory. The take-home message is that for more recent events and newly learned information, there's more difficulty there, but not in the long-term stuff. And then in terms of acquisition, maybe you can't learn as much as fast as you used to, but you can still learn it just fine and you can hold on to it. You can't always retrieve it as fast as you wanted, but it's still there. Language, there's some areas where there's some declines there. Visual spatial tends to not change too much except for some construction abilities. And in executive function, unfortunately, there is more decline there, particularly after age 70. And this has been associated with the increasing gray matter loss that's sort of considered normal aging. And that actually happens, unfortunately, preferentially in the prefrontal areas. So what I do want to say, though, about all of these studies is that there is a selection bias. You're always going to get fewer people from the tails. Best health, absolute worst health, highest income, the wealthiest, the lowest incomes. A lot of the studies are cross-sectional in design. They have cohort effects. Other studies are longitudinal. That's great. Guess what? They're subject to attrition bias. The people that have the most problems die. But they're also subjected to, all of these studies are subjected to the fact that neurodegenerative changes associated with, say, Alzheimer's disease, they start potentially decades before symptoms are emerging in terms of functional decline. And so some of the folks that make up the study may already have prodromal dementia. So it's just the 100 caveats that you kind of can't let go of. So, that means the question gets asked, is it PTSD or early dementia? At least that's what I'm asking myself. And this comes from really two big studies from 2010. There's not a lot since then, which I find disappointing, and I'm not sure I understand the reason for it. But it's going to be an important relationship to pin down. We have to keep in mind the lifetime prevalence of PTSD. We have to think about the chronicity of PTSD, the fact that PTSD at any age can be associated with poor cognitive performance, some of the biophysical changes that can go along, especially with the chronic effects. There's so much research out there showing that PTSD is associated with all these different independent risk factors for dementia. So forget the PTSD alone, it's causing things that are causing dementia. There's a new article from 2016 that really nicely wraps up all the cerebrovascular risk factors and the increased risk for that. So I mentioned the two big studies, and they're both from 2010. Basically, the bottom line from those two studies is that you're 2 times as likely to develop dementia if you have a diagnosis of PTSD than you would if you did not. In the one study, this is the Yaffe and colleagues study, they looked for vets over 55 who had at least one visit during a period of time and did not have a diagnosis of dementia. And then they had to have a follow-up visit and they essentially need to have 7 years of records following up to see whether they then had an incident dementia diagnosis. They had pretty solid numbers in terms of how many people they were able to identify that fit these rules. And they found, as I said, that the vets with PTSD were twice as likely. The hazard ratio was a 2.31 there. Now, there's lots of other possible contributors, right? They thought about demographic variables. They thought about medical comorbidities, psychiatric comorbidities. And when they put everything together, there was still a hazard ratio of 1.77. So it's a pretty solid finding. There's problems with it. Anyone use the VA health record? So it's pulled from that record. I know when I read vets charts that sometimes there's a dementia diagnosis thrown in. I know there's vets without dementia vets with dementia that don't have a dementia diagnosis. So there's a certain muckiness about it. They certainly ran into that when they tried to decide, well, was there a greater risk of a certain kind of dementia? And that's when they ran into the problem that a lot of providers, when in doubt, just put in dementia. Well, back then it was not otherwise specified. Or they threw in Alzheimer's disease because that's the most common one. Yes, in the back.
Commonly, in my experience, anybody who's had any kind of exposure and has some psychiatric distress has a PTSD diagnosis somewhere.
So the comment for those on Zoom is that there's also a problem with those that have the PTSD diagnosis, is that sometimes that's getting applied, I guess the nicest way to say it would be say a little liberally. I can only speak for myself. The providers I know are very conscientious about when they do or do not apply it. However, I would agree that I think that really does happen. So there could be a lot of folks with PTSD diagnoses that maybe don't meet full criteria. And the challenge would be, is you don't know, do they meet full criteria all along the way? You know, there are these fluctuations in symptom expression to think about. So why might this be? I have up a few of the more prevalent theories. More importantly for clinical care, as I watch my dwindling clock, I think is that there can be a real interaction between PTSD and dementia symptoms or the actual full syndrome. And that is that as you lose your more recent memories, or they aren't retained, I should say, these traumatic events become more and more proximal. They become fresher. There's institutional environments as folks go into long-term care, whether it's a nursing home or any kind of assisted living, and this can really trigger a lot of things. Being forced to take off your clothes and get in the shower is horrible. It's horrible. And yet our care environments are not necessarily designed to have this in mind. Think about the learned coping responses and post-trauma life successes that someone's had. You're losing your memory of that as well. In John's case, he's left with, let's imagine he did have dementia and he's losing more recent memories. At some point, he might be left with the image of himself as just that guy who was this is a quote, alcoholic who couldn't hold a job. And so all of that positive ego and it would just be lost. So, and then again, in terms of placement, increased agitation, behavioral disturbances, this is why people get kicked out of living environments. And what we don't want is folks to end up homeless or unsheltered. So We want to, even if we don't diagnose dementia, if there's not that problem, we want to keep an eye on that. So you use tracking measures like the PCL. You don't need to do a full CAPS on everybody every time you see them, but the PCL takes like 2 seconds to administer. The veteran or the older adult fills it out themselves. You can either screen for PTSD, you can monitor over time. But keep in mind, the questions on the PCL, at least 50% of them actually refer to changes in memory and attention. So to hit on Dr. Chen's earlier point, I always recommend doing a MOCA as well, or vice versa. If you've got someone with a memory concern and there's any reason to suspect PTSD could be involved, give them a PCL as well. So we're always thinking about our differential diagnosis when it comes to memory. And then in John's case, I really am going to run out of time. What would you do if you scored 30 out of 30? Maybe focus on the PTSD symptoms short term. 25 out of 30? Starting to get cuspy. Well, what would your plan of action change if you got 20 out of 30? And you might really think about that in terms of the type of therapy you're even doing for the PTSD, and definitely based on the profile on the MOCA. If there is retentive memory problems, you might want to figure out how to have a more now-focused therapy rather than one that requires the person to do homework and remember things and come prepared. Let's see. So maybe mental health treatments discontinued. I always recommend communicating with the folks' primary care docs to have them continue to monitor for cognitive change. I actually did neuropsych testing in this veteran. There were only mild weaknesses. There was no reason to diagnose any kind of a cognitive disorder. There was improvement in PTSD symptoms. Sleep was still kind of problematic, but the prazosinate definitely helped with the nightmares. So monitoring over time is what's happening now. All right, and I am really going to run out of time. So I would just briefly like to share with you some of this clinical demonstration project that we put together. The idea, as I'm going to move quickly here, was for these vets that kind of were in that gray zone to think of things that might be more supportive for them in terms of improving locus of control, positive self-appraisal, and sense of self-efficacy. We wanted to do education with VA providers, but also then providing informational tools for the veterans themselves, and then also developed a memory skills group. This is just a quick glimpse of the pamphlet explaining kind of how PTSD and memory can interact that was created. It's just a bifold pamphlet. And then just background on why you'd want to do a memory skills group. There's lots of good reasons. There's the peer support that comes with being in the group. It's very expensive to do one-on-one memory skills training. And frankly, I don't think the groups would have been that successful one-on-one. I think the folks that were in part of the group really enjoyed each other's interactions, problem-solving things together, coming up with goals together. There's a lot of positive effects there. Since I am going to run out of time, there's just a little blurb pull here for the article Stephen Fielke and I just had published in Federal Practitioner describing this memory skills group and some of our preliminary results. We did not develop this as a research project. So it was more QA/QI questionnaires. I mean, our goal was like, are the vets going to like it? Are they going to stay? Are they going to attend these sessions? It's a big pain in the rear end to come to the VA once a week for a group. And then in terms of inclusion-exclusion criteria, a diagnosis of dementia was an exclusion criteria. Folks could have some objective memory problems, but not that full dementia diagnosis. So here's what the sessions looked like in terms of the content headers. But I want to say, do you notice that only 6 and 7 actually say memory skills or memory strategies? What these guys really needed as much as like learning mnemonics is they needed SMART goals. They had never made their own identified behavioral change goals, and helping them learn how to develop this was really fun to do. We had a memory model to help them better understand. It was sort of a graphic representation of where PTSD can have an effect in sort of the neuroanatomical construction of new memories and attention. And then behavioral activation was just kind of a constant reinforcement throughout. And we also included mindfulness-based stress reduction, kind of a primer on that in every session. It was this thread that went along. And in addition to other things we wanted them to try for memory, we wanted them to try to practice mindfulness every day. And what was nice about that is we had in every group, I think we've had at least one person who had actually taken a mindfulness-based stress reduction class, and it made believers out of the rest. I could have sat there and talked about how great it was, and they would never have cared or believed me. But having the other vets there to really support that, or to try it out with, and sometimes fail, sometimes succeed, was a really nice piece. I am not going to talk about the chart review project. We just wanted to take an in-depth look at the first 50 to see, I had this hypothesis that the healthcare utilization would actually increase after the group, that they would they engage in mental health services, that they would get that PT they would need to get for the foot that keeps them from exercising. And I would just say at the end of the day, and there's some demographic information and information on coexisting medical conditions. At the end of the day, there was no significant increase in mental health and healthcare utilization across a broad array of services. There was a trend toward a reduction in overall services afterward. What we realized, though, when we started digging into this is, oh my gosh, what a heterogeneous group of white men we had. I mean, they weren't all white men, but they really were very diverse in terms of how healthy they were, how many psychiatric disorders they had. We had folks come in super high functioning, other folks lower functioning. And so this hodgepodge of where people started from just kind of nullified being able to find some kind of group result. And I realized how silly it was that I thought that I could pull that out of this. Also remembering that visits, actual healthcare visits, are not necessarily a good marker of healthcare or improved anything. Let's see. Also, when we saw new engagements, we saw that they weren't necessarily new engagements. They were often re-engagements. So veterans had engaged in mental health services maybe when they first started with the VA. They dropped off for 5 years. And after our group, they did start going back again. So I thought that was positive. So here are the bolded findings are from those questionnaires pre and post. This is from an initial sample of 63, the first 63 participants. We found increases in their sense of self-efficacy. We found decreases in their numbers of endorsements for depressive symptoms, and we found an increase in satisfaction with life. What I consider to be the biggest success is that PTSD checklist, the PCL, did not increase. By having these vets come in and do this memory skills group where PTSD was their common element, we didn't make their PTSD worse. So that sounds silly, but it's kind of a big deal. No, it wasn't a trauma-focused group. In fact, we made a big emphasis that PTSD treatment was not what was going on. However, the guys talk to each other. You know, there is some conversation that goes on, and there's some extra thinking about having PTSD that goes on. So there's a bazillion limitations for this. We've got more folks now that we need to incorporate into the analyses. We've had 4 women participate in 2 different groups, 2 in each group. Total success. I wasn't sure how that was going to go because it kind of always felt like a guys network in some of the other groups, but it went really well. The commonality of having served, I think, overrode some of those guy, man, woman thing. High retention rate, but we've got a lot. You know, if this were a research project, it would fail on so many levels. But I think for what we were going for, it was quite successful, and we've done a lot of exportation. I've used telehealth to help run the group with the Coeur d'Alene CBOC and also up at Mount Vernon. The psychiatrist there now runs groups independently. I don't join in. And then also more and more of my older vets are using their smartphones, or at least they can turn them on. So trying to incorporate that into more of the memory skills, I think, is kind of the next step to update this. So thank you all for your attention. I think that these are kind of the key points I want to send home. I think we really have to consider that we can play a very supportive role for our older adults who have this constellation of symptoms. And at the end of the day, we always want to find a way to have acute symptoms not become chronic symptoms. Just like I'd like to stop ever getting to diagnose dementia. For additional information, these slides will be available after today, so you'll be able to access some of these links. There's a great page dedicated to older adults on the National Center for PTSD's website. And that's it. Thank you very much. And the veteran in the upper right is actually my father. So if anyone thought, why is an officer being portrayed as a guy who was drafted? That is an officer. The description did not quite fit him, but.
Does anybody got any studies to see what